Good afternoon. Good afternoon, students. Sorry, I got held up in some activity. I tried to manage anyway. The thing is, now we were discussing about various anxiety disorders, and in this, we are going for treatment. We have seen various drugs recently, and what are the choices in different kind of this anxiety disorder that we have seen. Let us see some of the medications for these generalized anxiety disorders. So, what has to be there? The guidelines suggest a few things very important. If there is any comorbid disease like depression or any other affective or schizoaffective or maniac disorders, then primary disorder to be treated first. Okay, because most of the time anxiety is what we can say implication. It is because of the basic disease, and therefore the primary disorder should be treated first. If the GAD is due to because of the misuse of the substance or any addictive substances or illicit use substances, then this substance misuse can be complication of GAD. So first that withdrawal treatment has to be done, and no harmful substance use should not be contraindication to treatment of GAD. But the dependent or harmful substance should be treated first, or de-addiction program we call it that should be done first. If the person with GAD chooses to have a drug treatment, because as I told you, it is that way not very severe. If it can be treated with the cognitive behavioral therapy or what we can say counselings, then there may be patient, or they may say that okay, we do not need any treatment, we'll do it, we'll manage. But if they accept, okay, they need a treatment, in that case start with the SSRI. Usually sertraline should be offered first, but only problem that it is not licensed at many countries for anxiety disorder. It is licensed for this psychiatric diseases. So in that cases it should be, whenever it is given, then it should be informed consent should be taken, just like a clinical trial, and then it should be documented. Particularly the patients, if sertraline is given, they should be observed very carefully. If the sertraline is ineffective, then we can go for other SSRI or SNRI, and accordingly check what are other conditions simultaneously. If there is a tendency to produce a withdrawal symptom like paroxetine and venlafaxine that can cause, then definitely it can be given to the patient, but the care has to be taken. In what sense is the dose tapering should be there, observation should be there, and what we can say augmentation and switch over of the treatment can be done slowly. The side effect profile and potential for the drug interactions can be checked. Then the risk of suicide, particularly tricyclic antidepressants, if you know, they are having many side effects and they have many drug interactions also. The risk of suicide and likely toxicity in the overdose, example venlafaxine can do it. So that care has to be taken. Person's prior experience with the treatment with individual drug, if you have got documentation available or the patient has got a good file maintained, then on the basis of that you can think that which drug the patient has taken, which the patient can tolerate, and which drug are effective in that. If the patient cannot tolerate SSRI, SNRIs, then pregabalin should be the next choice. Then pregabalin we have discussed earlier, it is a GABA analog, and normally benzodiazepine should not be given for the treatment of GAD in the primary or secondary conditions, except short term measure for during crisis, that is when the patient is not being controlled and immediate control is needed, then benzodiazepine should be a good one. No antipsychotic drug should be given for the GAD in a primary care until and unless we have seen that there is a failure with other treatment, and then we have to introduce it along with the existing treatment, then only we can give any antipsychotic drug. Before prescribing any medication, the treatment option should be discussed, and the concern of the person has to be checked, particularly if he has got any information or ideas about or his basic what we can say previous treatment records are there, then in that whatsoever things are fully explained reason for prescribing and providing information on what can be the different treatments are there, what can be the benefits of it, and what are the risks which are associated with this treatment, how the medication should be taken, and if discontinued, then how it should be discontinued to avoid any kind of relapse or withdrawal symptoms. So this all information patient it should be given to the patient. In that there is a stepped care model is there, that is used to organize the provision of services and help the people with these generalized anxiety disorders, their families, caretakers, and practitioner, so that most effective way of treatment can be done. In that, what can be done is least intrusive, most effective interventions are done. Example of that is complex treatment, which is there. Or rather, what we can do is we'll go by stepwise. What we have got two basic things in that. One is focus of intervention, and other is nature of intervention. So we'll start from downside, that is step 1 to step 4, instead of coming from up to down. So step 1, whatsoever all the known and suspected presentation of GAD, that is any symptoms are there when the patient brings this complaint, then identify and assess it. You know how to assess it. We have seen various questionnaires, we have seen various what we can say how to judge it, just like DSM-4 and all, various scales are there. So using the different scales or questionnaires, we can identify, we can assess, and accordingly we can grade it mild, severe, etc. Then accordingly we can educate the patient about what is GAD, what can be the treatment option, and how it can be actively monitored, how we can do it. Now, if we have seen earlier that we can have various options, like we can go for cognitive behavioral therapy, and with that this if it is controlled, if the patient is happy, then we will not go for treatment. Just now we have seen. But if the patient needs treatment, then we'll see that is the diagnosed GID, it has not been improved after education and active monitoring in the primary care or cognitive behavioral therapy, then we'll go low intensity psychological intervention, individual non-facilitated self-help, individual guided self-help, and psychoeducational groups are there, sort of CBT with there. Then GAD with an inadequate response to step 2 intervention or marked functional impairment. Then we'll go for choice of high intensity psychological intervention, that is cognitive behavioral therapy, applied relaxation for drug treatment. See, you can see that since GAD is not that severe kind of problem, we are resorting to cognitive behavioral therapy till maximum time. Means first 3 steps are basically on counseling, guidance, and cognitive behavioral therapy and psychological intervention. That is, these are 3 steps we are doing, but still it is there a complex treatment which is refractory to all these impacts. Then there is a marked functional impairment like self-neglect or high risk of self-harm is there, too much anxiety is there. Then in that cases we can give treatment like various drugs. We have seen what are our psychological treatment regimen: input from multi-agency teams, crisis services, day hospitals, or inpatient care if patient has to be admitted. So these are various ways by which we can do. So if it is not making a big benefit, then we are going for that. Once it is there, we'll go for the secondary care, because many times because of the severe anxiety and marked functional impairment which is occurring with the thinking or what we can say thoughts of self-harm or suicide, significant comorbidity like substance misuse, personality disorder, or complex physical health problems, self-neglect. So in that cases we can simultaneously go for different treatment. Then step 4 treatment, we have seen in step 4 only we are going for treatment. We have seen various treatment modes. Example of that are sertraline, then venlafaxine, and all other drugs. We have seen that how these drugs are useful. So accordingly we will go for this treatment. Combination of treatment can be undertaken only by the practitioners with expertise in the psychological and the drug treatment complex. because when we have a combination of treatment, then there are chances of more adverse effect or their own interaction with each other, and therefore that has to be taken care with. The anxiety disorder which are refractory to various treatments, and after full discussion with the person about the likely advantages and disadvantages, then only combination has to be used. So these are what various type of generalized anxiety disorders and the treatment for that. The second kind of anxiety disorder is called as a panic disorder. Panic, already I told you, panic means all of normally there were no sign, but all of a sudden there is something which is occurring and it is unavoidable. Then it becomes a panic disorder. All of a sudden there is a big accident, you are there in that vehicle, suppose, or something is there, something close relative is hospitalized, and you have to take care, and you cannot think what can be the next thing. Then particularly it was very common with very severe stress is there. All of a sudden situation comes. So these are all panic disorders. All of a sudden this fear factor comes in. So this is an acute attack usually. Generalized anxiety can continue. It can be sort of chronic because usually it is not acute, but panic is usually acute. So what we can do is offer an SSRI, which is licensed for panic disorder, like citalopram, paroxetine or sertraline can be given for that. If it is not suitable for the patient or there is no improvement after 12-week course, then venlafaxine can be given, or imipramine, clomipramine may also be considered. The clomipramine, imipramine are not licensed, so you need to have informed consent, because again, as I told you, if they are licensed, means it is proven they are approved for that particular that particular disease or disorder. But if it is not there and you think that, or there are reports like there is a benefit, then because benefit may be in a very few people, so in that cases if you are using it, then you have to make as informed consent. It is sort of a clinical trial, although drugs are in market, but we call it as off-label use, or the off-label means whatsoever use the drug is approved for. So instead of that, if we are using that drug for any other use than that, we call it as a off-label use. So we can give benzodiazepine or sedating, antihistaminic or antipsychotic. It should not be prescribed in the first instance until and unless again emergency, as we have seen earlier. Then 3 open trials, they suggest that metrazapine may be efficacious for the short-term treatment of panic disorders, and some double-blind parallel group studies, they found that comparable efficacious to fluoxetine, but all 4 studies use small samples. So if we remember, if you got this, then evidence-based medication, we have seen earlier some of the examples of it. So if it is not there, then it becomes the COR, if you remember, class of recommendation. So this will not be a first class, it can be 2B or 2A or 2B, because clinical trials are there, but the data are not sufficient, they are not well designed. The positive open trials and case series of valproate, vigabactrin, then levetiracetam have been published, but again more control evidence is not there, and therefore they are not clear. The efficacy and the side effects should be observed for at least 2 weeks from the treatment, and then at the 4th week, 6th week and 12th week, and after 12th week, if everything is fine, then we are continuing the treatment. If not, then we will discontinue and we will go for other treatment. After 12 week, if the treatment is okay, you are approving it, there are benefits, and comparatively side effects are less or manageable, then you can continue treatment, and then review should be taken at every 8 to 12 weeks. So that means initially you have taken all the care. In the meanwhile, however, you can inform the patient to give the inputs indirectly if any problem is there. If there is an improvement after 12 weeks, continue use for 6 months at optimal dose, then taper the doses. In all CNS and particularly hormonal drugs, glucocorticoid, etc., you will see that you have to taper the dose. When stopping, reduce the dose gradually over an extended period. Refer to specialist mental health services after failure of 2 intervention. If there are 2 intervention and they are not useful, then go for the very specialist services of psychiatric department. Alternative to drug therapy like psychological treatment, that is cognitive behavioral therapy, self-help, that is bibliotherapy, support groups, exercise. Now what are support group? Support groups means self-help means you are guiding, and then you tell the patient that yes, if this happens, then if you get this, this is a panic disorder type of disease, this type of symptoms are there. When as soon as they start when the happening, then immediately be aware of it and try to fight with this, try to cope with this, and try to avoid this. So this is what self-help is there. Or get engaged in any other activities. There are support groups. So those which are having similar, there are many groups for different condition. Example, for alcohol, there was very famous, that was called as a alcohol anemics. So this was the group which will try for withdrawal of alcohol addiction from the people. Then go for exercise. So these are various alternative or non-pharmacological treatments which would be useful. Then next is OCD. I told you what OCD is. OCD is what? That is when the person is having repetitive actions, and that too very cognizable. That means one can notice it. They are noticeable that whatsoever the thing happening is not correct. The person is doing it again and again several times. So this is obsessive compulsive disorders. Because of that, or without that particular activity, the person cannot do anything. This is called as OCD or obsessive compulsive disorder, and in that the first line treatment we can have, that is SSRIs like escitalopram, fluoxetine, fluoxamine, paroxetine, sertraline. They all are licensed for OCD. Onset of effect is delayed up to 12 weeks. This again, if you remember all the treatment of depression, you will find that onset is very less. Actually, this was one of the issue which was raised with the monoamine theory, when people have this postulated that there is a problem with the monoamines in the CNS. Then in that cases, this monoamine therapy, that because of the imbalance in the monoamine, example, if the monoamines are more, then it is a mania type of disorder, that is high type of order, and if monoamines are less, then it is a low type of disorder. So this was called as a monoamine theory related to CNS diseases. However, later people have shown that if it is a monoamine, then why it is taking so much time, that around 2 week, 3 week, 4 week, or rather sometime in more than that, for drugs to show the effect, because we are giving drug, we call them as SSRIs or SNRIs, then this they will immediately increase the level of amines in the synapse. So if they are increasing, then why it is taking time, and it is difficult to answer, because why this is happening. So the reason, and therefore it is not clear why it is. So this takes 12 weeks to show the onset of effect. Till 12 weeks no effect can be. So 12 week, even though effect are there or not, anything is there, still the treatment has to be continued. The trials of SSRIs in the OCD have underscored the importance of using doses in the upper end of the dosing spectrum. As per the NICE guideline, there is an if there is an inadequate response to standard SSRI dose and no significant side effect at 4 to 6 weeks, then gradually increase in the dose can be done in the line with this whatsoever guidelines are there. The effective treatment is there, then continue for at least 12 months to prevent relapse and allow it for the further improvement. Then review continued use of the drug with the patient 12 months after remission. Check whether there is a decrease in the severity and the duration of the initial illness. Check the number of previous episodes. Then check the presence of residual symptoms, if any. Check any concurrent psychosocial difficulties the person has got, and then accordingly you can decide. If continued beyond 12 months after remission, gradually review the need for continued treatment. Agree this with the patient and record the notes. you can use clomipramine when an adequate trial of at least one SSRI was ineffective. So, in that case we can use clomipramine and the SSR was poorly tolerated, or the patient prefers clomipramine over SSRIs, or there has been previous good response with the clomipramine. So, in that condition we can give clomipramine. Then the people which are having significant risk of cardiovascular disease, the ECG should be conducted, and blood pressure measurement should be done before prescribing clomipramine, and intermittently it should be done to monitor the changes on that. For those which are having significant risk of suicide, prescribe only small amount because of its toxicity in overdose. If the response to standard dose is inadequate and there are no significant side effects, consider gradual dose that increase in the line of this SPC. Then continue the treatment for at least 12 months if it is effective. SPCs are the this specific psychiatric centers for the special psychiatric care taking. Then drugs which are not generally recommended for OCD, in all cases they are not usually given. Example of these are tricyclic antidepressant except clomipramine, because we have seen clomipramine is effective. Metrazapine, because there are very small evidence base for that. SNRIs, they show mixed result. In some patients they are effective, in some patients they are not effective. MAO inhibitors are not useful, and various anxiolytics like benzodiazepine etc., antipsychotics should not be used. So these are various drugs which are used into treatment. Now what are the other treatments? These are all various psychiatric conditions we have seen. What other treatment can be there? So whatsoever medications are there, we can check it accordingly. If required, then we can augment with the other drug. So antipsychotic augmentation, it is the most promising strategy with most evidence behind it. There are many trials which are having result published, and they show that patients who have not responded to SSRIs, the results are mixed, but there are positive studies of olanzapine, risperidone, quetiapine, aripiprazole and haloperidol that showing effect of this. A meta-analysis concluded that augmentation with atypical antipsychotics could be a helpful strategy for treatment in the resistant OCD cases. Benefits were the most evident with the risperidone, but the evidence were inconclusive for olanzapine and quetiapine. So these are there, but the studies shows that yes, antipsychotics can be augmented. Then we can have increasing the dose above the whatsoever formulary limits are there, that is British national formulary limits are there, and combining clomipramine with SSRIs, these are the areas of recent research, but are potentially hazardous because there will be addition of or additive effect in the adverse effect because of that, and then one must have good data for that. So these are all various drugs which we have seen. Already we have studied hypnotic sedatives, Z hypnotics we have studied. Yes, we have finished this. Drug dependence, yes, withdrawal symptoms are important at many drugs. Any treatment is there, then if it is all of a sudden stop, then we can get various withdrawal symptoms, and it will depend on the elimination half-life of the benzodiazepines. Particularly in benzodiazepines it is more common, but we have seen that in all cases it is there. Symptoms can be occurring to varying degree for varying length of time, and they are characterized as psychological, that is restlessness, agitation, panic, tension; physical, that is dry mouth, sweating, tremor, headache, sleep disturbances, palpitation, lethargy, these are all there; mental, that is memory and concentration impairment, confusion, depression, and some other signs like hypersensitivity to light or sound and anorexia. Severe and rare can be there, which can cause convulsions, psychosis, delusions, etc. So when it is there, So for that it is always better to discontinue the drug with a slow one. uh, Gradually it should be there, we call it as a tapering off. We have seen tapering in earlier classes, how we can taper off drug. And while tapering, this care has to be taken that how slowly we can do it. And simultaneously both things has to be observed. One is whether the condition is not getting relapsed, the symptoms are not going back. And second thing what is observed is there are no withdrawal symptom like situations. Are withdrawal symptoms are the other effects, and the relapse of the existing disease. So they are two different things which has to be monitored. If by chance relapse like condition is there, then immediately as per the protocol we can go for the treatment augmentation or continuation of the treatment as the case may be. While if the withdrawal symptoms are there, then there are various drugs are used for different drug to control the withdrawal symptoms. But when tapering is done, then very little chances that the adverse effects will be there. So this is where we finished most of the topics with the psychiatric diseases. Please go through this. If you have any difficulty, you can ask. Just a minute, I'll just tell you what are the topics we have seen. So this is the syllabus. Out of that we have finished all this: schizophrenia, affective disorders, anxiety disorders, sleep disorder, and along with that OCDs, obsessive compulsive disorders. So the topic number 1 is over from our side. You can prepare this. If you have any difficulty, you can let me know. Then sequence is second, you people have put for neurological diseases, so we'll go for that. That is epilepsy, Parkinsonism, stroke, Alzheimer, etc. You please be prepared about it. Please let me know what you are actually reading before coming to the class. The syllabus should be whatsoever will finish before examination, that much will be the syllabus for your first sessional, whatsoever date has been given. So one important topic we have finished. We'll go for few of these: epilepsy, Parkinsonism, etc. And then whatsoever will finish, we'll try to finish at least 1 or 2 from this, and then that will keep as a topic for your sessional examination. If you have any doubt, difficulties, you can just let me know, and we can just have a discussion on these topics wherever you have difficulties. So go through the guidelines, recent guidelines as far as possible. That will definitely help you. So take care, and just be in touch if you need anything.